Hello guys, welcome back. Hope you all are doing absolutely fine. So today we'll be continuing with our Pathology Exam revision series with our next topic, a very important topic from the point of view of examinations, which is Diabetes Mellitus. Definition. As per WHO, Diabetes Mellitus (DM) is defined as a heterogeneous metabolic disorder characterized by common features of chronic hyperglycemia with disturbances of carbohydrate, fat and protein metabolism. Metabolic syndrome consisting of a combination of metabolic abnormalities which increase the risk to develop diabetes mellitus and cardiovascular disease. Major features of metabolic syndrome are central obesity, hyperglycemia, low LDL, cholesterol and hypertension. Diabetes mellitus is leading cause of morbidity and mortality world over. Top 5 countries with highest prevalence of DM are India, China, US, Indonesia and Japan. In India, its incidence is estimated at 7% of adult population, largely due to genetic susceptibility. Classification and etiology. Classification of diabetes mellitus based on etiology divides it into two broad categories: type 1 diabetes and type 2 diabetes mellitus. Type 1 diabetes mellitus. It constitutes about 10% of cases of diabetes mellitus. It was previously termed as juvenile onset diabetes due to its occurrence in younger age and was called insulin dependent diabetes mellitus. It is further divided into two subtypes: subtype 1A diabetes mellitus, which is immune mediated, and subtype 1B diabetes mellitus, which is idiopathic. Type 2 diabetes mellitus. This type comprises about 80% cases of diabetes mellitus. It was previously called maturity onset diabetes or non-insulin dependent diabetes mellitus on obese and non-obese type. Other specific etiologic types of diabetes mellitus are, besides the two main types, about 10% of cases of diabetes mellitus have known specific etiologic defects are genetic defect of beta cells, genetic defects in insulin, disease of exocrine pancreas, infections, and endocrinopathies. Gestational diabetes mellitus. About 4% of pregnant women develop diabetes mellitus due to metabolic changes during pregnancy. Pathogenesis. Depending upon etiology of diabetes mellitus, hyperglycemia may result from the following: reduced insulin secretion, decreased glucose use by body, and increased glucose production. Pathogenesis of type 1 diabetes mellitus. The basic phenomena in type 1 diabetes mellitus is destruction of the beta cells mass leading to absolute insulin deficiency. Currently, pathogenesis of type 1 diabetes mellitus is explained on the basis of three mutually interlinked mechanisms: genetic susceptibility, autoimmunity, and environmental factors. Pathogenesis of type 2 diabetes mellitus. The basic metabolic defect in a type 2 diabetes mellitus is either a delayed insulin secretion related to the glucose load or the peripheral tissues are unable to respond insulin. Pathogenesis of type 2 diabetes mellitus is explained on the basis of these factors: genetic factors and constitutional factors, insulin resistance, impaired insulin secretion, and increased hepatic glucose synthesis. Clinical features: type 1 diabetes mellitus, polyuria, polydipsia, polyphagia. Type 2 diabetes mellitus, obesity, weakness, loss of weight. We'll cover this clinical features more in detail in the coming slides. Complication of diabetes mellitus. Both type of diabetes mellitus may develop complications which are broadly divided into two major groups: acute metabolic complications and late systemic complications. Acute metabolic complication: diabetic ketoacidosis, hyperosmolar hyperglycemic non-ketoacidic coma, hypoglycemia. Late systemic complication: atherosclerosis, diabetic microangiopathy, diabetic nephropathy, diabetic neuropathy, diabetic retinopathy, and infections. Diagnosis of diabetes mellitus: urine testing, glucosuria, ketonuria, single blood sugar estimation, screening by fasting glucose test, and oral glucose tolerance test. Complications of diabetes. As a consequence of hyperglycemia or diabetes, every tissue and organ of the body undergoes biochemical and structural alterations which account for the major complications in diabetics, which may be acute metabolic or chronic systemic. Both types of diabetes mellitus may develop complications which are broadly divided into two major groups: acute metabolic complications. Metabolic complications develop acutely. Diabetic ketoacidosis (DKA). Ketoacidosis is almost exclusively a complication of type 1 diabetes mellitus. Clinically, the condition is characterized by anorexia, nausea, vomitings, deep and fast breathing, mental confusion, and coma. Most patients of ketoacidosis recover. Hyperosmolar hyperglycemic non-ketotic coma. Hyperosmolar hypoglycemic non-ketotic coma is usually a complication of type 2 diabetes. Blood sugar is extremely high and plasma osmolarity is high. Thrombotic and bleeding complications are frequent due to high viscosity of the blood. The mortality rate in hyperosmolar non-ketotic coma is high. Hypoglycemia. Hypoglycemic episode may develop in patients of type 1 diabetes mellitus. It may result from excessive administration of insulin, missing a meal, or due to stress. Late systemic complications. A number of systemic complications may develop after a period of 15 to 20 years in either type 1 type of diabetes. Atherosclerosis. Diabetes mellitus of both type 1 and type 2 accelerates the development of atherosclerosis. Consequently, atherosclerotic lesions appear earlier than in the general population, are more extensive, and are more often associated with complicated plaques such as ulceration, calcification, and thrombosis. The possible ill effects of the accelerated atherosclerosis in diabetes are early onset of coronary artery disease, silent myocardial infarction, cerebral stroke, and gangrene in the toes and feet. Gangrene of the lower extremities is 100 times more common in diabetic than in non-diabetics. Diabetic microangiopathy and diabetic nephropathy, diabetic neuropathy, diabetic retinopathy, and infections. Diabetics have enhanced susceptibility to various infections such as tuberculosis, pneumonias, pyelonephritis, otitis, carbuncles, and diabetic ulcers. This could be due to various factors such as impaired leukocyte function, reduced cellular immunity, poor blood supply, and due to vascular involvement and hyperglycemia per se. Diagnosis of diabetes. Hyperglycemia remains the fundamental basis for the diagnosis of diabetes mellitus. In symptomatic cases, the diagnosis is not a problem and can be confirmed by finding glucoseuria and a random plasma glucose concentration above 200 mg per deciliter. The severity of the clinical symptoms of polyuria and polydipsia is directly related to the degree of hyperglycemia. In asymptomatic cases, when there is persistent elevated fasting plasma glucose level, diagnosis again poses no difficulty. The problem arises in asymptomatic patients who have normal fasting glucose level in the plasma but are suspected to have diabetes on other grounds and are thus suspected to oral glucose tolerance test. The American Diabetes Association has recommended definite diagnostic criteria for early diagnosis of diabetes mellitus as under: plasma glucose values and the diagnosis: fasting for more than 8 hours, below 100 mg per deciliter, normal fasting value, 100 to 125, impaired fasting glucose 126 and above, diabetes mellitus. 2 hours after 75 gram of oral glucose load, which is more than 140, normal postgrandial GTT 140 to 199, which is less than 140, normal postgrandial GTT 140 to 199, impaired postprandial glucose tolerance, and 200 and more, diabetes mellitus. Random value 200 or milligram per deciliter, 11.1 millimole per liter or more in a symptomatic patient, diabetes mellitus. The following investigations are useful in establishing the diagnosis of diabetes mellitus: urine testing, glucoseuria, and ketonuria, single blood sugar estimations, and screening by fasting glucose test and oral glucose tolerance test. Other tests, which include glycosylated hemoglobin. Measurement of blood glucose levels in diabetics suffers from variation due to dietary intakes of the previous day. Long-term objective assessment of degree of glycemic control is better monitored by the measurement of glycosylated hemoglobin. This is because the non-enzymatic glycosylation of hemoglobin takes place over 90 to 120 days. Lifespan and red blood cells HbA1c assay therefore gives an estimate of diabetic control and compliance for the preceding 3 to 4 months. Glycated albumin, extended GTT, intravenous GTT, cortisone prime GTT, insulin assay, proinsulin assay, C-peptide assay, islet autoantibodies, and screening for diabetes associated complications. Thank you.